Okay, we'll go ahead and start the next chapter. It's going to be neurodevelopmental and neurocognitive disorders, but we're going to break it up into two lectures. The first one's going to be neurodevelopmental. The second one will be neurocognitive, and I think we'll break it up by weeks as well. So just to give you an idea of where we're going to go, I think we'll go through about, I believe it's slide 42 on this PowerPoint. Okay, so in regard to neurodevelopmental disorders, again, these are ones that are going to be primarily starting in childhood. Now, that doesn't go for every single one of them. There can be ADHD that develops in adults. It's just fairly rare. Most people who are diagnosed as adults had symptoms while they were kids, but nonetheless, those arising in childhood, and again, we will come back to neurocognitive disorders, but neurodevelopmental disorders include ADHD, autism spectrum disorders, intellectual developmental disorders, disorder, learning communication, and motor disorders. So we're going to go over several of those today, and we're going to start with ADHD. So when we talk about ADHD, and just as a note here, ADHD is all encompassing now. There used to be ADD and ADHD. That is no longer the case. It is only ADHD. So, but I will break this down and hopefully be able to help you delineate between um, basically the hyperactivity piece and the attention piece. Okay, so first and foremost, all right. There has to be a persistent pattern of inattention okay, here's the thing, and or hyperactivity and impulsivity that interferes with functioning or development as categorized by either this category and or this category. It could be one or the other or both. Okay, so let's start with the inattention piece. Okay, we could just be looking at inattention, but there could also be inattention and hyperactivity and impulsivity. Or this might not be present, but then the hyperactivity and impulsivity might be present, okay? So that's how this kind of goes together. So with the inattention piece, you have to have 6 or more symptoms of inattention for kids age up to the age of 16 years old, or 5 or more symptoms for adolescents age 17 years and older and adults. Okay, so 6 or more for kids up to the age of 16, and then once they hit 17, you only need 5. All right, so these symptoms have to have been present for at least 6 months, and they've got to be inappropriate for the developmental level. So, I mean, I know this is common sense, but if you have a 2-year-old that is not paying attention very well, that's probably a 2-year-old. But if it's inappropriate for the level at which they are age-wise, then we could start to consider these symptoms. So, again, if we're talking about kids, 6 or more symptoms. So, the first one, often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or other activities. And I apologize for the dogs in the background as well. Okay. All right. So it's, again, not being able to give close attention to, again, just basic errors that could be made. 2 plus 2 is equaling 5. Maybe we're not completing the backside of the page. And again, that happens here and there with kids in general, but it's more so than what would be expected. They have a hard time holding attention on tasks or play activities. So they have a hard time sticking with something that they are doing. Also, they often don't seem to listen when they're spoken to directly. Again, that has to do with the focusing piece. They have a hard time sustaining focus. Also, they don't follow through on instructions, fail to finish schoolwork, chores, or duties in the workplace, so they lose focus, they're sidetracked. Maybe you ask your child to take the trash out, and in 2 hours, they still haven't done so, or you ask them to do it right away, and they just don't get it done. So they're not following through with things that they need to be following through with on a daily basis. And it's not attributable to a kid just being defiant or rebellious. Um, they could often have trouble organizing tasks and activities. So they're just disorganized in general. They often avoid, dislike, or are reluctant to do tasks that require mental effort or a long period of time. Again, this is going to be schoolwork, homework, any sort of project, any sort of even just things like building extensive Lego sets, putting together complex model, cars, things that are going to take extensive amounts of time. They aren't going to be overly interested in that. They often lose things necessary for tasks and activities. They're always losing their pencils. They're always losing their trapper keeper, their folders, their backpack, maybe their phone. They're often easily distracted. So again, you might be on task for a moment, then all of a sudden they're looking at something else, or they're talking about one thing, and then all of a sudden they're talking about something else. And they're often forgetful in daily activities. And even something as simple as, putting dishes in the sink, or again, taking the trash out, or remembering to get up to go to school, or leaving to go to school. Again, these are just basic daily activities that you would expect a kid to be able to do. They have a hard time doing that. Okay. And again, you're going to need at least 6 or more of these because we'll just talk about kids, 6 or more of these. And this has to have been present for at least 6 months. So you have to see it pretty consistently for 6 months. This can't just be like a week in which a kid just doesn't want to do something. It has to be at least 6 months that you are noticing these symptoms, or a clinician, or you can exhibit to a clinician that it's happening. Okay. So you can have that piece there. Or or you can have this hyperactivity and impulsivity piece. So again, 6 or more symptoms here for kids up to 16, 5 or more for 17 and above. And they have to have been present for at least 6 months to the extent that they're disruptive, inappropriate for the age level. They're getting in the way of the child functioning. So they're often fidgeting with or tapping their hands, feet, or squirming in their seat. They're often leaving their seat in situations when remaining seated as expected. They have a hard time sitting for extended periods of time. So these would be the kids that have to get up constantly, or asking to go to the bathroom all of the time. Or again, you can even look at adult. They have to get up and move around in the office. And again, these are situations in which it is expected that you are able to sit through a class, and they just can't. They often run about or climb in situations where it is not appropriate. And this is usually due to feeling restless. And so, they might be climbing on a bookshelf that might be in a classroom, or climbing on their desk, or climbing on top of their chair, or, they're running around. Again, these are situations in which it would not be appropriate to do so. They're often unable to play or take part in leisure activities quietly. Again, they're going to be loud. They're going to be loud and raucous. They're often on the go, acting as if, again, they're driven by a motor. They go, 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 go. They talk excessively. They'll blurt out an answer before a question has been completed. So before you even get a full question out, it's already been answered, because again, their brain is moving that fast. They often have trouble waiting their turn, and they often interrupt or intrude on others. So they're butting into conversations or games, and not waiting their turn and being patient. That patience piece is commonly not there, especially with this hyperactivity impulsivity disorder part of this. The impulsivity piece means that they don't have the ability to forego that impulsiveness or need to express themselves or move. That's just not there. So either both of those, both the inattention and the hyperactivity and impulsivity, or one or the other. Then, let me see here. In addition to one or the other, or both of those that we just went over, there has to be several of these symptoms that were present before the age of 12. So you just need to be able to identify that, oh, yeah, they started doing this at the age of 7, or they started doing this at the age of 10. If you can do that, you'll be able to, a clinician would be able to diagnose this if they're having extensive symptoms at the age of 14. Several symptoms have to be present in 2 or more settings. So this can't just be like an issue at school, which you might sometimes see. They're fine at home. They're fine when they go to church. They're fine when they go to the babysitter. But at school, it's a mess. these symptoms are just extreme. That doesn't count. It has to be across several different situations. So maybe it's at school, it's at home, maybe it's, when they're at grandma's house and it's at school, but it's across several contexts to show that it's a symptom of something that is beyond the environment itself. There's clear evidence the symptoms interfere with or reduce the quality of schools or social school or work functioning. Yeah, that's usually when people start to address it, is when it starts to interfere with kids' schoolwork. That's primarily when you start to see it. Even though it could be interfering with their ability to play with others, or again, with work, maybe people aren't showing up to work, they're leaving early, they're not completing all of their tasks. And the symptoms aren't better explained by something else, like mood disorder, anxiety disorder, dissociative disorder, personality disorder, and they have nothing to do with schizophrenia or psychosis as well. And okay, and then there's the specifiers, and this is where the and or come into play. So you can specify as like ADHD a combined presentation, and this is both if both the inattention and the hyperactivity impulsivity symptoms are in place. The next one is predominantly inattentive presentation. This is just if the inattention portion is in place, but not the hyperactivity. And then predominantly hyperactive impulsive presentation. So none of the inattention, but the hyperactive and impulsivity part is there. Now, this is something that I don't know if I've discussed this in previous lectures, but there's nothing, it's not it's not necessarily doesn't mean that, like, okay, they qualify for the hyperactivity and impulsivity diagnostic part, but not the inattention piece. But let's say they have 4 symptoms on that inattention piece. They may not qualify for the full disorder, but you would say, yes, the hyperactivity and impulsivity piece is in place, but they have traits of the inattention piece. So even though it's not fully diagnosable, that could still be recorded as traits and thus still treat that portion. Because it's probably not always going to be completely black or white with any diagnosis, especially when we're looking at this. There's going to be overlap. One might not be fully diagnosable, but the other is. But nonetheless, there's probably parts of both that need to be treated. Okay. And that is this. I apologize. And again, we have to have seen at least 6, and again, in kids, 6 symptoms for at least 6 months. And again, the presentation can change over time as well. Okay, so some factors that contribute to ADHD. I'm trying to see if there's anything else. I think I got problems. Okay, biological factors. Yes, there are genetic factors associated with ADHD. Parents can pass down the genes associated with ADHD to their children. Of course, there needs to be an environmental trigger to aid in the manifestation of those genes, but nonetheless, they have found that biologically, the cerebral cortex of those with ADHD is smaller in volume, and as a result of that, that's where that impulsivity can come into play, the inattention can come into play, because there's less executive function ability. That's where we're able to, be patient, slow down, think things through. That's all happening in that frontal cortex and the cerebral cortex. There's also less connectivity between the frontal areas of the cortex of the brain and the motor behavior, memory, and attention. Again, that prohibits the ability to slow things down and control things. There's abnormal function of catecholamine. This is going to be the epinephrine dopamine neurotransmitters, and those are stimulated in nature. And so at higher levels, you're going to see that hyperactivity, inattention, impulsivity. Genetic factors. Yes, there's a 74% heritability rate. That does not mean that an individual is going to get it 74% of the time, but that means that the genes associated with ADHD will be passed along from a parent to a child 74% of the time. That's the heritability piece. That does not mean that a child is going to get ADHD, but if those genes can be expressed, they can develop ADHD. Also, prenatal and birth complications, things like premature birth weight, prenatal exposure to smoking, prenatal exposure to lead, things like encephalitis, alcohol, have all been correlated with ADHD. Also, again, neurotoxin exposure, lead. Lead's not great, and encephalitis. So that's literally the swelling of the brain. Okay. So now we've got treatment for ADHD, and there's all sorts of different debates about the treatment for ADHD. Um, Depending upon the severity of it, a lot of clinicians will say to start with therapy, in regard to working toward managing symptoms instead of jumping straight to um, psychopharmaceuticals. Um, some I, Again, this is fairly controversial because sometimes it may be easier to medicate a child for ADHD than to work through the therapeutic interventions. And I know that can happen sometimes. But if the ADHD is manageable to a certain degree, therapy may be the best option because if the child has the ability to learn the skills to cope with those symptoms, um, medication may not be necessary. Okay. Nonetheless, very commonly, though, a kid is going to be put on medication. And so we have stimulant drugs, and these are going to increase levels of neurotransmitters because stimulating is going to increase the activity of them. And research suggests that methylphenidate is going to increase levels of dopamine. And these are your methylphenidate-based stimulants, concertafocal, metadate, and Ritalin. They block the reuptake of dopamine and norepinephrine in your brain. So once those neurotransmitters are released into the synapse and they attach to the receiving dendrite and they detach, they are not vacuumed back up into that sending axon. Instead, that is blocked, leaving more access to dopamine and norepinephrine in that synapse, and thus increasing the availability and the activity of it in the brain. So, um, in regard to that stimulating, that is going to increase the activity of those neurotransmitters. And let me get to the next piece, because again, what it sounds like here, because in regard to the brains of individuals with ADHD, it's going to work a little bit different. I should have prefaced with this, because if I do not have ADHD, if I were to take like a Ritalin, or we'll get down here with an Adderall, I'm not going to sleep. And I will not, I will be overly stimulated. We will say that. Because, okay, that's methylphenidate. Okay, has to do with dopamine and norepinephrine. There we go. Let's go to amphetamines, then I'll keep talking. So, amphetamines are going to be another type of ADHD drug. It mostly increases the release of dopamine and norepinephrine from their storage sites into the synapse. So, instead, or a less significant mechanism of amphetamines is slowing the reuptake of it. So in comparison, I mean, the methylphenidate prevents the reuptake of those neurotransmitters, enhancing their availability. Amphetamines just increase how much is going to be released into that synapse, but still increasing the activity of the dopamine and norepinephrine. And a couple of these different drugs are going to be Adderall, Dianavel XR. I don't know that one. You guys might. And then Vyvanse. Now, Adderall is interesting. Well, Adderall, Ritalin, a lot of these um, are interesting because, um, they can be commonly abused. Adderall is the one that we hear about more often than not. And some kids, adults, teens will use it like as a study drug or a drug to enhance their focus. But in effect, whether we like it or not, it's basically a controlled amphetamine. It is not methamphetamine, but it is a controlled amphetamine. Methamphetamine is a type of amphetamine, so it's kind of like a controlled methamphetamine. It can have a similar effect. Um, I'm just going to give this one little anecdotal piece of maybe it's interesting, I don't know. But I used to work with individuals who abused and were addicted to substances. And one interesting thing that I noticed is that I came across quite a few clients who had been abusing or currently abusing methamphetamine, and they had ADHD. Now, when they were using methamphetamine, again, there was obviously a lot of problems. Problems do not cease when you use meth. They just increase in number, but they were able to focus and get things done while they were on methamphetamine. However, when I started working with them, that meant that they were trying to get sober and get into recovery. And one thing that was kind of noticed was that like they couldn't focus, they couldn't get things done, they had a hard time remember to go and pick up their kids. And part of that was because the methamphetamine was actually working like these were. The only difference is that meth is illegal, it is not controlled, and it is not prescribed. And so this is where I'm going with this, is that when the individuals I worked with, they were in basically in the court system. Because in a lot of cases, their children were removed from the home, and as a result of that, they were in the court system trying to retain custody of their kids. And so the court wouldn't allow for any stimulants to be prescribed to individuals who were in the system because it's going to pop for amphetamines. And until that point, these were all abusable. And so somebody who was addicted and had addiction problems could easily abuse these. So the court wouldn't allow that. Luckily, while I was still working in this realm, they came out with Vyvanse. I want to say this was maybe 2013, somewhere in there, maybe 2013, 2014, probably before that, but right around there. And what Vyvanse is, it's still a stimulant, an amphetamine stimulant like Adderall, but the difference is you can't abuse it. So like with Adderall, it can be like crushed and snorted or abused, but Vyvanse is not because it has an extended release. And additionally, if you crush it, it loses all like stimulating properties. So it literally cannot be abused. So that was great because then that provided the rationale to allow the court for these individuals to get on a stimulant ADHD medication that helped them immensely. Okay. All right, so there's stimulants. There's also non-stimulants. The primary non-stimulant medication for ADHD fall into one of two categories, either norepinephrine modulators. These are going to regulate neurotransmitter norepinephrine, and blood pressure medications. So the primary non-stimulants prescribed for ADHD includes Strattera. We've got Strattera, Quilbree, Catapres, Catbay, Tenex, Intuiv, Symetril, and then antidepressants as well. So in regard to like Strattera and Quilbree, these are going to be norepinephrine modulators in order to basically ensure that there is enough norepinephrine. It's not going to enhance the norepinephrine in the brain like the stimulants will. Also, there's alpha agonists. These blood pressure medications also will work in regard to in a modulating fashion for norepinephrine. Also, Symetril. This is for Parkinson's. It's Parkinson's medication. It was originally an antiviral drug. And then antidepressants, norepinephrine, dopamine reuptake inhibitors. Again, we're looking kind of at dopamine here. And the most common is going to be Wellbutrin, which is kind of I really didn't talk about this when we talked about mood disorders and antidepressants. Wellbutrin is a little bit different in regard to being a norepinephrine dopamine reuptake inhibitors. Most antidepressants are going to work primarily on serotonin and norepinephrine. This works on dopamine, which is fascinating. Wellbutrin also helps if somebody is working on quitting smoking. So, okay. In regard to these, and more so, and again, it depends on who usually, okay, commonly, again, we're talking about a young kid, they might be put on like a Strattera. And then obviously there's all of these as well. It just depends upon an individual's biology, what's going to work, what's not going to work, what is their situation. Also, in regard to this, I didn't mention that, again, if I take any of these, I'm going to be awake for days. But somebody who has ADHD, once you enhance that norepinephrine and dopamine in the cerebral cortex, that is going to increase their focus and calm them down. For example, when I was helping raise my stepson, um, we would actually give him caffeine, and that would calm him down. So for me, if I drink caffeine, I'm going to be up all night. But for him, he drank caffeine and it calmed him down and helped him focus. And so the increase in that caffeine enhances that norepinephrine. And so in regard to that, that increase of norepinephrine actually enhances the focus for individuals with ADHD. So, okay, there's some CBT techniques as well. And again, it would be great if everybody with ADHD would start out, working with a therapist. Just know that that does not happen. That's the reality. So these are some of the techniques that can be used. So like cognitive restructuring. So in regard to this, some individuals, again, this could be work with anybody, but with kids, I don't even know why I bother. I'm not going to get it done anyway. We're trying to reframe everything into something more constructive and positive and helping the child learn that they can do that and they can get their homework done. Turning it into something like I've had trouble getting things done in the past, but I'm learning new tricks and coping skills to stay organized and on task. So I'm confident now because I have these new coping skills that I am going to get it done. That actually enhances the chances they're going to get it done. Also, distractibility delay. So this helps somebody become more aware of the distractions that interfere with their productivity. So maybe it's a TV, maybe it's a phone, maybe it's a pet. One strategy involves using a timer to see how long you can stay focused before your mind wanders. And so once you know how much time you have, you can use this to plan your successive approximation exercise. So like if you can focus for 10 minutes, you might want to ensure that each step of the task is only like 10 minutes long. And so maybe it's like, okay, I have to get this textbook read and I can read 4 pages in 10 minutes. Okay, I'm gonna read four. I have to have this chapter in the textbook read by the end of the week. It is 16 pages long. I can read 4 pages in 10 minutes. I'll do 4 pages a night. Those take 10 minutes. And I know by the end of 10 minutes, I'm going to lose focus, but I have those 4 pages done. It also teaches individuals to write down the distraction rather than attend to it. That can also help with the distraction. Identifying the distraction and working through it. If you're in the middle of a 10-minute task, try to take note of the distraction and then address it once your 10-minute time task has completed. And so maybe you're reading your 4 pages like you would in your 10-minute time span, but there's a notification on your phone that goes off. You would write down, yep, that distracted me. Then when that is done, you can address it. You can remove it from your room or wherever you're at. And so the next time you do not have it present. And so it's basically structuring your day around what you can do and working with that at the time. Okay, so when it comes to prevalence rates of ADHD worldwide, it, population surveys suggest it's in about 7% of kids. Cross-national prevalence ranges pretty widely from like 0.1 to 10%. The prevalence is higher in special populations like foster kids, correctional settings, which does make sense. And then across national meta-analyses, they found ADHD in 2.5% of adults. So in relation to how this develops, like a lot of parents, again, are going to observe like excessive motor activity when the kid is a toddler. But again, this can be hard to tell like what is normal and what is not before 4 years old because a lot of the criteria that I mentioned are the normal behavior of small children. It's most identified during elementary school. It's relatively stable through early adolescence, but some individuals have a worsened course of antisocial behavior as they get older, which this is the concern with this as well. And that most individuals with ADHD symptoms of motoric hyperactivity become less obvious in adolescence and adulthood, but difficulties with restlessness, inattention, poor planning, impulsivity, that can continue. So again, the development and course of the disorder is all going to be based on really the identification and treatment of the disorder. There a substantial proportion of kids with ADHD do remain relatively impaired into adulthood. But again, it is going to be based on what type of treatment do we get, what type of coping skills are developed. So Um, I think there was something else. It's more frequent in males than females, a ratio of approximately 2 to 1. There is risk for suicidal thoughts or behavior in adulthood as well, associated with increased risk of suicide attempt, especially if there's a mood, conduct, or substance use disorder. Um, yeah, it is associated with reduced school performance and academic attainment, as we've kind of talked about. Poor job stability later on, more issues with interpersonal conflict. Um, there's a couple of disorders. I'm just going to go through these. I don't usually go through differential diagnoses, but there are certain ways that ADHD can manifest that can result in behavioral issues that can get fairly concerning. Even though ADHD is concerning in of itself, but it can kind of take a darker turn. And I'm not saying this does not happen for everybody, but there are correlations between like ADHD and conduct disorder, which can snowball into antisocial personality disorder if left untreated and becomes extreme in nature. Um, and again, that's not going to happen very often, but it can. And so there's a couple differential diagnoses. So there are some symptoms that are going to cross over with these other diagnoses that have to be taken into consideration as well. So like oppositional defiant disorder. These individuals, they may resist work or school tasks that require them to put effort into it because they don't want to do what anybody else says. Their behavior is characterized by negativity, hostility, defiance. And so a clinician is going to have to determine, okay, like, is this just defiance? Are they just not wanting to conform? And do they just want to rebel and say no? Or do they not have the cognitive capacity to focus on their work and get it done? So they're going to have to be able to tell the difference between that. Intermittent explosive disorder. They both of these disorders share high levels of impulsive behavior, so they could look a little bit similar. But those with an intermittent explosive disorder show serious aggression. That's not characteristic of ADHD. And those with intermittent explosive disorder don't really have problems sustaining attention, where those with ADHD commonly do. Let's see here. There could be a learning disability present, intellectual developmental disability, autism spectrum, reactive attachment, anxiety, post-traumatic stress, depression, depressive disorders, bipolar disorder, disruptive mood, um, dysregulation disorder, and substance use disorders, personality disorders, psychotic disorders, medication-induced symptoms of ADHD, and neurocognitive disorders. So I don't know if there is a longer list of differential diagnoses that need to be taken into um, consideration when a clinician is trying to diagnose a kid with ADHD. Okay. So let's go ahead and move on to autism. And yes, I know we are missing some of the disorders, but you are more than welcome to get into the DSM to check those out. So when it comes to autism, and again, autism is something that I think that we're going to be learning about for a long time. I think there's more that we don't know than we do know. Um, and this form of the diagnosis is fairly new. We used to have varying levels of like autism, but now we just have autism spectrum disorder. It's just plain. It's just plain cut. This is it. So with the diagnostic criteria, okay, so um, a child is going to have persistent deficits in each of these three areas, related to social communication and interaction, plus at least two of the four types of restrictive repetitive behaviors. All right, so you're going to have for A, because we've got A, B, yeah, we got A, B, and then remainders are pretty standard. So for A, you have to have persistent deficits in social communication and social interaction across multiple contexts, as manifested by the following currently or by. Okay, and again, you have to have all of these areas. There's deficits in social emotional reciprocity, ranging, for example, from abnormal social approach and failure of normal back and forth conversation to reduce sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. So um, this could range from anything to, let me see here. Oh, okay. Sorry, I'm trying to give you the best examples. Though if there is language, it's often one-sided. Again, they're not going to socially reciprocate. Um, they're not going to share feelings. They may not express nonverbal language, or nonverbal communication as well. They have a hard time, again, if you ask a question, answering it in a way that continues a conversation. They may not share anything about themselves. It might be very emotionless. If you tell the funniest joke in the world, they might not laugh. They might not be able to understand it. That could be part of this as well. Let's see here. Okay, I think I got as much as I can on that one. Okay, deficits in nonverbal communicative behaviors used for social interaction ranging, for example, like poorly integrated verbal and nonverbal communication. And again, things like atypical use of eye contact, reduced use of eye contact, no eye contact, for example, um, joint attachment, a lack of pointing, showing or bringing objects to share interest with others, um, follow the inability to follow someone's like pointing or eye gaze. If somebody points in a certain way, you kind of look over, they don't do that. Let's see here. They don't really use expressive gestures spontaneously in communication. And again, this is going to be very much on a kind of like literally a spectrum. Um, so yeah, abnormalities, eye contact, body language, deficits in understanding and use of gestures, to a total lack of facial expressions and nonverbal communication. So there just might not be anything at all. There's no responsiveness. There's no really, again, eye movements aren't going to follow, that gestures aren't going to be used. Um, Also, deficits in developing, maintaining, and understanding relationships. And this can go anywhere from, again, adjusting behavior to suit various social contexts. So, understanding how to behave at home in comparison to school, to difficulties in sharing imaginative play or making friends, to absence in interest in peers. So, not having any interest in having relationships with others. Let's see here. Again, so this could be anything from with a young kid, they don't take part in like imaginative play. So like playing house, playing Barbies, building with Legos and like playing, I don't know, pirates. Um, Later on, they may play, but there has to be very fixed rules. Again, that's not minus the imaginative piece. Older individuals might struggle to understand what is really appropriate in one situation but another. So, like, they may not understand that they need to behave differently in a job interview than they do at home with their mom. So they might actually prefer solitary activities. You might see them interacting with like people that are way younger than them or way older than them. Um, they want to develop relationships, but they don't really understand what that entails. Um, Also, relationships with siblings, coworkers, and caregivers are also important to consider, like again, in terms of reciprocity. Okay, so there has to be aspects of all of those. And again, it's going to range at a spectrum from everywhere from, again, we started up here from just kind of being awkward and not having really the ability to have a back and forth conversation to not responding at all to social interactions. Then everything from not from poorly integrated verbal and nonverbal communication, again, so not being completely able to use appropriate like pointing, eye contact, position of the body when interacting with others. to no facial expressions. Then all the way again, ranging again, relationships, changing your behavior to understand like a certain situation, to no interest in interacting with others. So there has to be something in that realm, and this is where this is very vague. To a certain, it's vague, but it's very widespread. This is not as tight of a box as some of these other diagnostic uh, diagnoses. So, okay, you got to have aspects of all of those three. Then there needs to be a restricted, repetitive pattern of behavior, interests, or activities that is manifested by at least two of the following, currently or by reported history. So maybe you come in and you're 12 and this was going on. They're able to report that, yeah, oh yeah, that was going on when they were 8. So that would be what history means. So Uh, stereotypical or repetitive motor movements, use of objects or speech. So simple motor stereotypes, lining up toys or flipping objects, echolalia, idiosyncratic phrases. So this could be everything from like, okay, like hand flapping, finger flicking. I know you've seen the hand flapping. An example of somebody who actually, I mean, I think when you watch this, I don't know if he's still going to be famous, but Sketch on TikTok, he has been diagnosed with autism spectrum disorder, and he does this. Um, Repetitive use of objects like spinning coins, lining up toys. The repetitive speech could be like the parroting of heard words. They might use you when they refer to themselves. Things like that. Insistence on sameness, inflexible adherence to routines, ritualized patterns of verbal or nonverbal behavior. So if there's like a small change in something, but they will get very, very upset. I mean, I like my schedules, I like the structure of my days, but I still have the ability to adapt if something happens or challenges arise or I get sick. We're able to adapt. Individuals with autism spectrum disorder may not be as easily able to adapt. So yeah, distress is apparently small changes, like taking a different route to school. That could result in a breakdown. This very rigid black and white thinking. This is in here. Yep, certain greeting rituals. Again, you have to take the same route, eat the same food every single day. Again, these structures are very um, important to these individuals. The interest. Yes, there's going to be highly restricted, fixated interests that are abnormal in intensity or focus. So, um, yeah, we could be talking about like a toddler, and maybe they're attached, like, incredibly attached, like a pan, like let's say, or like a piece of string, or maybe a kid that is attached to vacuum cleaners. Or it could be like an adult that spends hours on hours and hours writing out times tables. And so again, it's a fairly unusual, and it's pervasive. It's a fixation. Obviously, it could be something that is more. I'm giving very out of the box examples. It could be something that's less out of the box than those. Also highly restricted, oops, sorry, hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. So this could go everything from like if they could touch a stove, they're not going to feel anything. To if they get a hug from somebody, it's like somebody stabbing them with a knife. So either too much sensitivity to the outside world, or even in regard to sounds. That's overstimulating and overpowering, and can result in shutting down. It could even be taste or smell as well. That could result in, again, it's overstimulation. Okay, so you need at least two of those. And then, of course, okay, symptoms must be present in the early developmental period, but they might not be fully manifest because of social demands, exceed limited capacities, or maybe they're masked by learned strategies in later life, so they're able to find ways to cope with it. But the symptoms have to be present in early development, in, again, earlier childhood. Even if it's diagnosed later, it can still be reported that, oh yeah, that was happening at that point. There has to be impairment in social, occupational, or other important areas of functioning, which is very common. And it's not better explained by something like an intellectual disability, global developmental delay. Uh, Intellectual disability and autism frequently co-occur. And to make the comorbid diagnosis of each, social communication should be below that expected for general developmental level. So that does have to be taken into consideration. Let's see what else I got here. Okay, just in regard, a couple of things about this. I don't think I have all of this in the PowerPoint, but some of the first symptoms people see with autism spectrum disorder is usually like involve delayed language development, not being interested in social interaction, or unusual interactions, um, kind of outside the ordinary play patterns, um, like they carry toys around, but they never play with toys, and unusual communication. So, um, like they understand the alphabet and letters, but they don't respond to their own name. So those could be some of the first indicators of autism spectrum disorder. And when it comes to this, okay, so some altered abilities in autism spectrum disorder. So individuals they may have a hard time recognizing emotions. That's again having a lower level of cognitive empathy, which is the ability to look at somebody's face or listen to their voice and identify like, oh, they're angry or sad. It also affects the ability to recognize distinctions in emotions. They may group emotions into broader categories than people who don't have autism, like interpreting all of pleasant emotions as happy and all of them as sad, even though we know like there's rage and grief and sadness and depression, but they will put them all under sad. It's kind of like how people might categorize like crimson as red, whereas other people would insist that crimson is a different color from red. Like there are many different reds. It's the difference between saying, oh, all of the spectrum is red instead of like, oh, it's crimson and rose and then red. And I'm bad with colors. So whatever other shades of red there are. Again, having the inability to or hard time adapting to change in plans. They may not cope well with things being changed last minute. Processing sensory information. Many individuals with autism can have sensory overload. A bunch of information incoming all at once, loud noises, bright lights. That it feels painful and causes, and I know this is very casual, I apologize, anxiety and panic attacks as the brain fails to integrate the information properly. Have a hard time regulating emotions and thought patterns. So, in order to regulate, again, they might rely on something like repetitively tapping a pen, fiddling with a blob of blue tack, to help keep their brain from responding to distracting things and keeping them focused. They have a harder time with their executive functioning. So keeping on track, keeping track of time, a calendar, budgeting, making sure that everything's on time during the day. That's a little bit harder as well. We kind of went reduced eye contact, withdrawn, losing language skills. Yep, signs usually seen by 2 years of age. Again, it's every kid is every individual who's going to have autism spectrum disorder, it's going to look different. It's like with every other disorder, it's going to look different. With autism spectrum disorder, we know even less. And so I am of the opinion, professionally, we know less about this because there's such a wide range of potential symptoms in this disorder that it makes it very hard to completely conceptualize. Let's see here. Yeah, some kids with autism have difficulty learning, some have lower than normal intelligence, but then some have normal to high intelligence. They learn quickly, but they have trouble communicating, applying what they know in everyday life and adjusting to social situations. So again, the severity can sometimes be difficult to determine. It's really based on the impairments and how they impact the ability to function. So does the individual have the ability to take care of themselves and shower and get themselves to school? That's usually the level of what we determine in regard to the level of to determine the level of severity. So this is one way to conceptualize autism spectrum disorder. So it doesn't go from like not severe to severe. That's not how autism spectrum disorder is conceptualized. It's not. It's more like the color spectrum. All of these different parts of the spectrum are different conceptualizations. It's not a range. It's not mild to severe. It is not that. It's not 0 to 100. It is different parts that make up the full spectrum. It's like the color spectrum. There's no like light, like there's no like 0 to 100. There's no light to dark necessarily. I know it's like dark to bright and light. Anyways, but it's not it's not a ratio level of measurement. It is more so nominal in that it's different labels along a spectrum that we created. Okay. I hope that makes sense. If not, shoot me an email. We'll talk about. So again, this is what people think autism looks like a little quirky, definitely autistic, tragic autistic. Okay. They think it's that type of spectrum, but it's not. It's not one condition. It's a collection of related neurological conditions. It's so intertwined, it's impossible to pick apart that professionals have stopped trying. So really, we've just kind of combined all of it together. So there might be somebody who struggles with pragmatic language, some with social awareness, some monotropic mindset, information processing, sensory processing, repetitive behaviors, and neuromotor differences. And then they can all overlap in different ways. That's why this is so difficult. So again, all autistic people are affected in one way or another in most or all of these boxes. It's a rainbow of traits. But again, how affected they are is going to be what differs. And if you only check one or two boxes, then they don't call it autism. They're going to call it something else. So if you only struggle with communication, that's a social communication disorder. That's not autism. Or if you only have problems with body movement or control, it's called dyspraxia, or we have in the DSM, developmental coordination disorder. Or if you just have sensory processing issues, that's sensory processing disorder. But if you have all of them, that's when we have autism. So we bring all of it together at differing levels. That's when we get to autism. And for somebody to be considered autistic, again, they have to have difficulty in multiple categories across the spectrum. And again, the diagnosis depends on evidence that you do span the spectrum in observable ways. So you kind of have to show, like, yes, you do have this and this and this, and you have shown that you have issues with this and this and this. Some of the commonalities are going to be less obvious and are not required for diagnosis, but most are pretty universal. Each individual is affected strongly enough in one or more of the categories for it to be disabling in some way. So usually there's at least a category that is going to cause some sort of dysfunction and stress. Otherwise, it may not even be reported. But each person's dominant color palette, again, it's going to look different. So here's some examples. I'm just going to go over one of these. If you want more of them, I think there's 3. Yep, there's 3. You are welcome to go ahead and go through the PowerPoint. So, okay, this is person 1. Okay, so for example, this is what an individual could look like in regard to all of these categories. In regard to their pragmatic language, they kind of tend to miss social cues. They interrupt or accidentally bore people, so they just go on and on and on about whales for hours, and they don't recognize like, oh, I should probably change the subject. Social awareness, they forget to say hello or goodbye. They don't think to ask for help when they have difficulties, and they don't reach out to friends. So just a little bit withdrawn. The Irish goodbye. Monotropic mindset, they obsess over special interests. They have a hard time switching between tasks. They don't multitask, and they struggle with executive function, kind of that organization, staying on time, remembering you have to be here at this specific time. Information processing, absorb written word easily, great memory, has a hard time following verbal instructions, has a hard time navigating unfamiliar environments, and is easily confused. Again, so even with this, okay, this might get in the way a little bit, even in regard to just navigating the world. Sensory processing, sounds, certain sounds, sensitive light, dislikes notoriously picky about taste and texture. So there is some sensory things going on here. Repetitive behaviors, taps finger, spins ring on the finger, especially when stressed, sucks thumb in private, rocks. Again, that helps with focus. And then neuromotor difficulties. Somewhat clumsy, has trouble with coordination and manual tasks, may enjoy one particular sport like swimming or horse riding. So in general, okay, this individual does not need a ton of support. I mean, probably daily support to a certain degree, but in general, is probably pretty independent. Whereas, I'll go over this individual just to kind of show you the difference in the fact that this is the same disorder. So with language, unable to speak due to motor problems, picks up on social cues very well, does understand body language. They are very interested in people, but they have social anxiety. They tend to get fixated when they're stressed or upset, but they have a wide variety of interests. So again, with these, they're pretty functional. Information processing, difficult to adjust to new locations, new people, but they basically have a photographic memory. This individual may be kind of savant-like. Sensory processing, but here's the thing. Any sort of mild touches, it burns like fire, sounds completely incapacitate the person. So in regard to that, they're going to need immense amounts of support regarding this sensation overload. Arm slap, the person may hum or grunt, may be fascinated with the motion of water or feeling of sand. Again, doing that in order to try to focus. And they're in regard to neuromotor differences, the body seems to have a mind of its own, finds it very difficult to move in a purposeful way, often mistaken for having intellectual disability. So in regard to that, they probably are going to need additional support in order to manage those physical issues. And again, they cognitively pretty uh advanced, but when it comes to again some of those physical issues, it's going to cause dysfunction and be disabling in a certain amount in a certain way. So these two people are very different. Same diagnosis. Then there's a third, but um person two. Okay, we'll just talk about person two. These two, and again, who is the most autistic? I don't know if that's something that should be labeled that way, but who is going to need more support through life? Person one, probably going to be described as high functioning, even though they might have a hard time living and working independently. Person two, they are probably considered to be severely autistic. They can't speak. And they don't necessarily have the ability to understand what goes on around them, and they have a hard time controlling their body movements. But nonetheless, they're all gonna be disabled in some way. And there's person three if you want to go into them. Okay. We've talked about some of the signs. I will let you go ahead and go through some of these. And there's more signs. Okay, so there's some contributors to this. For example, it is a polygenetic disorder, and so that means, or polygenic disorder. So that means there are a multitude of genes that contribute to the development of autism. It has been evidenced by family and twin studies. There's more than 100 genes on different chromosomes that could be involved in causing autism spectrum disorder. Two different degrees. A lot of people with autism have slight changes, these called mutations in a lot of these genes, but the link between genetic mutations and autism is going to be very complex. So most people with autism have different mutations and different combinations of mutations that can kind of explain the vast array of symptoms. Not everyone with autism has changes in every gene that scientists have linked to autism, though. Many people without autism or autism symptoms also have some of these mutations that have been linked to autism, which is fascinating. And so this means that different genetic mutations probably play different roles in autism. So certain mutations or combinations of mutations might cause specific symptoms. They might indicate like, okay, how severe are these symptoms going to be? And then increase the propensity as to whether somebody might develop autism. So somebody with like one of these gene mutations is going to be at greater risk than someone without the mutation. Also, so if somebody is susceptible to autism because of that mutation, again, then we're looking at certain situations that might activate or express those genes, resulting in this symptom. So if like an infection or contact with chemicals, like again, we talked lead in the environment, allegedly could cause autism in someone who is susceptible. But someone who is genetically susceptible might not get autism if they have the same experiences. So it's kind of like a crapshoot. It's a flip of a coin. They're also looking into biological factors other than genes that might be involved in this. Some of it might be involved with like brain connections, so neuronal connections, growth or overgrowth in certain areas of the brain. So enhanced neuronal connections are not enough. Metabolism issues, that's energy production, and the immune system, which might be related to infections affecting. Okay, so some of the treatments, let's see how where we're going to go to. Okay, I've got some experiences. Okay. Okay. So the treatments, applied behavioral analysis. This encourages desired behaviors, discourages undesired behaviors to improve skills. This can include discrete trial training and pivotal response training. The DTT is going to use step-by-step instructions to teach a desired behavior response. They're going to be broken down into simple parts, and then desired answers are going to be rewarded. Undesired ones are going to be ignored. Thus, again, this is operant conditioning. PRT is going to take place in a natural setting instead of a clinical one. This is going to help to improve pivotal skills that are going to help the person learn other skills. So this might be something like, okay, initiating communication with others. And that could lead to, working on nonverbal behavior, again, like something like eye contact, gestures, starting to understand how to respond to another person. So again, it's those pivotal skills that are going to lead to the development of other skills. Then developmental approaches, again, speech and language therapy is going to commonly be used. Some people with autism communicate verbally, others communicate through signs, gestures, pictures, electronic communication devices. Occupational therapy could be used to help somebody live as independently as possible, things like dressing, eating, bathing, relating to other people. This could also include sensory integration therapy to help improve responses to sensory input. So like that sensory overload, learning coping skills to help manage that. And then also physical therapy, that can help improve physical skills, just like fine motor movements. So like being able to use a fork, being able to zip a zipper, things like that. Also, there's some educational approaches. This could be like treatment and education of autistic and related communication handicapped children. Teach approach. It's based on the idea people with autism thrive on consistency and visual learning. In general, and again, that's kind of a generalization that autistic people are much more visual learners than non-autistic people. I'm blanking on some of an individual who's very famous. She's basically an agricultural researcher. It's blanking. She talks about this, but anyways, it provides teachers with ways to adjust the classroom structure to improve academic or other outcomes. So like daily routines can be written or drawn and placed in clear sight. Boundaries can be set around learning stations. Verbal instructions can be complemented with visual instructions or physical instructions that might help in the retention of that information. Social relational approaches, so improving social skills, emotional bonds, and this could be between parents or peer mentors. Floor time, encouraging parents and therapists to follow the interests of the individual to expand opportunities for communication. So again, kind of just learning how to connect. Relationship development intervention involves activities increasing motivation, interest, and abilities to participate in shared social interactions. Social stories, providing simple descriptions of what to expect in a social situation. Social skills groups. This gives people with ASD opportunities to practice social skills in a more structured environment. And so learning how to like initiate a conversation can be done in a safe space instead of, walking up to somebody at school, at work, and starting that conversation. Okay, I found some of these experiences. I'll mention a couple of them. So let's see here. Certain sounds make me want to vomit out my insides and makes it feel like my ears are bleeding. I can't stand touching cotton balls or velour and velvet fabric. I can't sleep without a blanket on me, even at, I don't know how hot 30 degrees Celsius is, but I think it's pretty hot nights. I mean, there's a lot of sensory overload issues there, or sensory issues there. This individual, my obsessive interest in film makes me super knowledgeable for my current profession. It's not uncommon for people to ask how I know so much about movies, comics, TV, and whatnot. I seek out and retain a lot of information when I'm into a topic. As my also autistic son calls it, we suck it into our brain for later. So again, that's that hyperfixation on something. Here's one. I struggle a lot with social interactions. I used to be very awkward when I was younger, and I would just say embarrassing, cringy stuff. And I was bullied a lot for it. Now I just stay quiet and I struggle to make conversation with new people. The flow of conversation just doesn't come naturally. When I do talk, I can't speak in the right tone, and people usually think I'm just rude. I have to really force myself to appear friendly, but it just feels wrong and just makes me more anxious. I'm sorry for my dogs yawning behind me. Very sorry. So again, there's those social interaction issues. Eye contact is tricky. It's not so much that I hate it or it's uncomfortable. I just don't think to use it. So that's part of it is like for any of us that are not autistic, it is cultural in nature, but after you do learn it, it does become second nature. But these individuals would have to consciously think about doing it in order to activate it, basically. But also, when I look people in the eye, it feels oddly confrontational. So this individual's never really understood eye contact. Um, so there's a couple more on there if you're interested. Otherwise, we've been on this video a long time, so I am going to stop it right there for today. If you have any questions or concerns, feel free to call me. Shoot me an email. Feel free to shoot me an email. Let me know if there's anything that I can do for you, and we'll talk to you soon.